I'm going to cover three topics in the next 10 minutes. One is why it's essential for us to accelerate adoption of automation in healthcare, and I'll talk about what I mean by that. Second, I'm going to talk about why we haven't seen automation rapidly grow in healthcare over the last decade, given all the digital infrastructure. Third, I'll talk about what Medcurio's role is in trying to accelerate the growth of automation. I'm going to start, though, with a personal story. I was holding this back, even though Lee asked for some stories with applications. I'm going to tell you my favorite one. It's rather mundane. But I have directional dyslexia. And I know there's probably 13% in the room that have that same problem. But mine is incredibly precise. I'm 100% reliable. I'm always 180 degrees off. So in my early years, I got lost a lot. I was fine with that until 2005 happened and Google Maps came out. And I instantly knew exactly what to do with it. It was, for me, a remarkable experience. I just gave it a destination then, as I do now, and it optimized my guidance, got me to my destination. Whenever I overrode it with my dyslexic instinct, it calmly got me back en route. An extraordinary experience in my mind, and I still think that now, after almost using it for 20 years. And I use it 3 or 4 times a week. And the magic behind that technology is the magic behind every successful automation solution. And that magic is the way in which the app calls for data in real time and seamlessly integrates it with what you're doing in the moment. Right? So that magic of it always tracking you, notifying you of what's coming, comes from real-time access to data. It is the critical ingredient for automation. And it's one of the ingredients that's really missing in healthcare. My focus around automation is what health systems do within their 4 walls, mostly because they face daunting problems. So our mission is to enable health systems to accelerate the use of automation. And it's a critical mission, I think, because of the dual financial pressures that health systems face. They've been around for years. They're going to continue to evolve, and they're putting pressure on systems that's eroding the quality and access to care. One pressure is the continued growth in the cost of labor. Labor accounts for about 60% of healthcare costs, and the cost of that continues to exceed the inflation rate. And with the shortage of doctors and nurses that are projected over the next 10 years, we can expect to see more of the same in terms of competition for that rare talent. The second is a process that's been unfolding for 4 decades, and that is that the share of reimbursement that comes from public sources continues to grow as a share of all reimbursement. And so the average reimbursement that's being paid for services is going down as the costs are going up. So that dual pressure we used to be able to handle with commercial insurance, because commercial insurance paid around 130 to 150% of cost. Medicaid pays about 72% of cost. Medicare pays about 90% of cost. So that pressure is unavoidable, and we're well past the time of when we should have automated. I want to sort of transition to where we are with the use of electronic health record data. I'm sorry for these slides; they somehow got macerated in this in sending these over. But when I was at Geisinger, when I joined Geisinger in 2003 to start the research center, it was a really exciting time. The electronic health record was really at the center of everything. And not only was it evolving and being used in clinical care to improve the effectiveness of care, but it was being used in secondary ways to evaluate Geisinger's value-based programs. And that was mostly a good thing. But what evolved over time, both at Geisinger and Sutter, and it was obvious if you lived in a health system, was the way in which more and more work was being pushed to the front line of care. And it wasn't like anybody was designing it. You had technology, you had data. The data was used to evaluate how things were working, to understand how to fix them better. And every fix had something that got pushed to the front line of care. And that process continues to this day. The force of driving more and more work to the front line where there's a finite capability of people on the front line to take on more work results in the kind of process where new things come in and then some older things are dropped and a little chaos happens, burnout happens, and things of that sort. The state that we're in today is a product of a process basically that people were engaged around and continue to be in terms of driving more and more work to the front line. So data are largely used not to do work for the front line. Data are largely used to move work to the front line. And what I think the shift that we have to make is that real-time use of electronic health record data needs to be at the center. And the reason for that is that electronic health record data are not only just connected to clinical care, but they're connected to back office stuff like revenue cycle management and supply chain management and other back office activities. And because of that connection, EHR data can be leveraged to be used in real time to automate processes. So it's not only just the back office, but obviously reducing clinical burden through in-basket automation, for example, or automating documentation, making encounters more effective with truly effective decision support, because I would say that we don't really have that. And I think the evidence from the literature is pretty clear on that, especially for the more sophisticated kinds of decision support with regard to best practice advisories, for resource optimization, and in particular for patient support services. One of the great failures over the last 40 years is we've never really been successful with some of the key patient support services like care coordination. And it's an area where I think we can make huge advances. But right now, we actually don't have substantial real-time access to electronic health record data. Part of the reason why we can't automate it is that we can't liberate the data to help us automate. If you're ever in a healthcare system, and I'm going to speak specifically about Epic EHR because it's the most commonly used and I have a lot of experience with that. You have three keys that you can use to access electronic health record data in real time. They're known as FHIR, vendor or public APIs, and HL7. Those three keys give you access to about a third of the electronic health record data for real-time use. They're a real pain to use. They can't be modified. They can be modified, but if you want to modify those keys, it takes a lot of work. And the challenge is that if you have an automation app and you can get those 30% of the data, but you need another 20%, what will happen is wherever there's a gap in the data that you need, there will be a gap in what you can automate. Right? And so often people end up with these applications that have been scaled back to the data that they can get. And in fact, in general, I would say that we've all scaled back how we think about automation to the data that we can get. And in fact, our imagination has been constrained in that same way. So the limited ways in which we can access data in real time constrains not only what we can do today, but it constrains us in how we think about what we can do tomorrow. I spent 16 years in two health systems trying to automate with data in real time. I did it both on the clinical care side and I tried to do it in scaling clinical trials, phase 3 clinical trials in health systems. And after 16 years, our group at Sutter decided that we were focusing on the wrong problem. We concluded that the application side of automation solutions was going to continue to get better and better, no code, the more sophisticated, enabled with AI, and all those things. But the back end was still going to drag it down. It was going to still make it very, very difficult for automation apps to really be successful, especially in the era of AI, because AI demands much, much more diverse data. AI demands that you modify the data needs from time to time as you tune the AI engine. So we decided to switch. We got out of the application design business. We concluded that if we're inside and we're first in line to get access to IT resources and we can't make it work, even with external funding and other resources, then the market's probably unlikely to make it work. And so we should try to solve the interoperability problem so that folks can actually do things on scale. So we invented a whole new technology that's completely different from anything out there. We invented a technology that would have met our needs when we were at Sutter. It's a no-code API platform. It takes a couple hours to install. We've created a cache version of that technology so far, so we use it, health systems at Epic use it. And those health systems sit at a interface and they log in and they point and click to select the features of the population that they want, however precise they want it. They point and click to select the data fields that they want an API to call. And then our technology automatically manufactures the API. Now, when I was at Sutter, it took a team 4 to 6 months to do that process and get it in production. With our technology, it happens in a couple of hours. And periodically, when I had applications, I had to modify those APIs when I was at Sutter. That would take 6 to 8 weeks. With our technology, you point and click, and it's done in minutes. So the speed with which you can both put APIs in production to power automation apps is unparalleled. And the speed with which you can modify the back end as you modify the front end is also unparalleled. But it's what we need if we're going to really move into the age where automation becomes an asset and taking work off the table for health systems. Systems that use our technology are able to do electronic health record integration with applications with about 10% of the effort. So we eliminate 90% of the IT resources required to do that. They get to market quickly, and they get into production really quickly, reducing that time from months to days. And of course, they can expand what they automate because they have 100% access to electronic health record. There is no data field that they can't get access to with our technology. What I like most about our technology is that you can scale it across instances. So if you're a large health system, let's say like a Kaiser, where you may have dozens of instances of Epic, you build once and you export everywhere. If you are part of a registry for rare diseases and you have a dozen participating entities, you build once and you standardize the APIs that are being used everywhere. So the scale with which you can manage real-time access to data is, in my mind, one of the powerful features of this technology. I'll just close with where I started. When I think about those patient support services that I think are really fundamentally important, I think they're transformational. I think about a journey like a breast cancer journey. It's a very long journey. There are 5 phases to that journey. It takes a couple of years. There are lots of steps within the journey. Women go into that journey unguided for the most part. We've tried experiments, actually, we did this at Sutter, where we had a nurse navigator. We got external funding to have a nurse navigator do the work. We learned 2 things from that. Thanks for that introduction. It's a pleasure to be here. I'm going to cover 3 topics in the next 10 minutes. One is why it's essential for us to accelerate adoption of automation in healthcare. What I mean by that. Second piece is just going to be about why we have the workflow, where you can feed data into the workflow in a way where somebody can get a lot of work done with relatively little effort, but the patient experience is substantial in terms of what you're doing for them. My favorite story about Salesforce was with our first customer. They couldn't get Salesforce to work for a very, very basic service. That was just sort of a call service for people calling in. They couldn't get one data field to move over, and that was the patient's preferred mode of contact. So they had to work from 2 screens. They tried for months to try to get this to work. They adopted our technology in that time. In 2 hours, they built the API and it was in production and they fixed the problem. The remarkable thing, though, is they went from a period that most health systems are in, which is being blind to the future of what's possible and being confined and thinking about what they could do because of the limited access they could get to data. They went from 10,000 transactions a day on our technology platform, our API platform. 18 months later, they were doing 1.5 million transactions a day. What they did is they realized that they could get access to anything. And what they did is they expanded their patient support services to care gap closure to referral management to care coordination. They dramatically expanded that because it was so easy to move data as they wanted to. So I'll just close with this last slide that the opportunities for health systems, in my mind, to automate are substantial. They are, I think, what's required to really address the financial pressure and squeeze that they all face. And this is just one scenario where if you're effectively automated because you had access to all data that you needed for a $6 billion health system, they generate enough net revenue basically to solve the financial challenges that they face. So I'll stop there and thank you for your attention.